Next, we go to Dr. Saroj Das, who is from Imperial College of London. He's going to be talking about a very pertinent thing in present times, microcirculatory changes and activation of thrombosis in COVID-19 infection and its impact on venous and arterial thrombosis. We have all seen this in our practice during the COVID time this year, that we lost many patients, we had to treat many patients of acute MI, DVT, strokes, just because of hypercoagulable state which was induced by the COVID infection and after the COVID infection because of the systemic response of the body and the vessel wall. So none other than a prolific researcher, Dr. Saroj Das, would be talking about it.
Okay, thank you very much. As Dr. Khanna alluded to the fact that we are all immersed with the uncertainty of this COVID-19 infection. And I don't think we still know where is the end in sight. Is it too distant, as some say, 10 years or more, or it may be sooner? I think we are all impatient to see the end of this problem. And but the reason for discussion or this presentation this afternoon is different. Now, let's look at what this pandemic has done to us. There has been over 267 million people who have suffered from this pandemic. Almost 5 million, in excess of 5 million people have lost their lives. In the United States, the death rate is approaching to about 1 million. In India alone, there has been over 5 million deaths, 500,000 deaths from this pandemic. But interestingly, Pfizer claimed that they have saved the world several $1 trillion. But if you look at the real figure, it has affected the global economy. The direct cost of treating this pandemic has been in excess of $11 trillion to the global economy. And furthermore, the indirect cost, which has been calculated over $10 trillion, and the cost is rising. So let's put it aside, because this effect, we will never be able to calculate it properly, because as we do not know when is the end of this problem. So the reason for presentation this afternoon was that I was actually asked to address two important problems that is seen with COVID-19 infection. That what are the significance of the microcirculatory changes that is being seen in COVID-19 infection? And the second question that was asked to me was, what is the magnitude or the severity of arterial and venous thromboembolism in COVID-19 infection? So I did a review, and this has been published in one of the British Hospital journal, and I'm just presenting you some of my outcome of this review that I did. So before we try to address those two questions, we must understand that what are the reasons of the COVID-19 infection? How does it affect the body, and where does it start? And as we all know, that the COVID-19 infection, firstly, it affects the upper respiratory tract, where there are a lot of ACE2 receptors are distributed in the respiratory tract, in the endothelium, in the kidneys, and this virus binds to the ACE2 receptors, and then it infects the body. When the infection becomes severe, it then infects the type 2 pneumocytes, which are located in the lower respiratory tract, and gradually destroys these type 2 pneumocytes, which are not only responsible to maintain the gas exchange, but also they are responsible to the release of the surfactants, which are important for the gas exchange in the lungs. And when this process continues, and it leads on to the pulmonary edema, or what is called ARDS. And together with this, what triggers this process is what is called the cytokine storm, which is the hallmark of the COVID-19 infection. Now, what is the cytokine storm? The cytokine storm involves the release of various cytokines, various interleukins, various chemokines, including the granulocyte stimulating factors, the tumor necrosis factors, VEGF, and so on and so forth. And together with that, there is activation of the reactive oxygen species, reduction of the protective function of oxygen-free radicals. And both the mitochondria and endoplasmic reticulum, they also release a lot of proteins together with hypoxia-inducible factor. And these all lead to the damage or apoptosis of the type 2 pneumocytes more and more. And ultimately, this leads on to the lack of gas exchange at the lungs level, and that leads on to the hypoxia and so on and so forth. And this ultimately results in the ARDS. Now then what happens, there is activation of the endothelial cells with endothelial injury. Now this then activates the von Willebrand factor, the platelets, and the various adhesion molecules which are released together with the activation of the collagen. That leads on to development of the thrombus plaque. And together with the activation of the various coagulation proteins and inactivation of the various natural anticoagulants, this leads on to the irreversible phase of activation of the coagulation in these patients. So this leads on to the what is called development of thrombosis, capillary clogging, and we assume this is the way how activation of thrombosis takes place in COVID-19 infection. Fortunately, it does not happen to every patient. Those patients who are severely affected by this problem, and most of these patients are seen in the acute therapeutic unit situation, environment. And this leads on to various other complications. And this is why we see development of venous as well as arterial thrombosis. So let's look at the first question that I was asked. Are there any microcirculatory changes that happens in COVID-19 infection? And what is the significance of it? Yes, there does happen some microcirculatory changes, but the fact is, these are the changes that is seen not only in COVID-19 infection, in many patients who are being treated in the intensive therapeutic environment, they all have some microcirculatory changes in their system. Now, what is their significance? The microcirculatory changes signify the severity of the COVID-19 infection, number one, and how this affects the outcome of this patient from this severe infection. And thirdly, it also helps the intensive care personnel how to manage these patients appropriately so that they can recover from this severe COVID-19 infection. Now, there are many ways of assessing the microcirculatory changes in these patients. Like indirectly, you can do pulse oximetry, you can do lactic dehydrogenase, or you can do what is called infrared spectroscopy, but these are not accurate and they do not reflect the exact changes that takes place in the microcirculation. And particularly to do this assessment at the bedside in the intensive care unit for our patient, we need different portable, which are reliable and which will be reproducible devices such as handheld video assisted microscopy or skin fluorescence study. And these are reliable and this helps the intensivist to, first of all, to see the severity of the problem and assess and monitor their progress with treatment. So with this, there are several changes that is being assessed in the sublingual blood flow to see the microcirculatory changes that I described in my slides. So these microcirculatory changes do help in monitoring the patient and outcome of this patient suffering from severe COVID infection. Let's move on to the next question that I was asked with regard to the activation of thrombosis. We have several reports. Many of these are anecdotal reports, and one such report from Japan, hospital records from Tokyo. And they looked at 516 patients admitted to the hospital, and this is a retrospective observation. And they found equal incidence of arterial as well as venous thrombosis. And as you will see from this slide, that most of these patients have got quite severe arterial thrombosis, suggesting that these were the group of patients who were being managed in intensive care unit environment. But this does not reflect in the real life scenario as to how many patients do really suffer from deep vein thrombosis or acute arterial thrombosis. So therefore, we looked at a larger evidence, and these are the couple of evidences which are something around 65,000 patients, where they looked at the frequency of venous and arterial thrombosis, and this was published this year, in fact earlier this year. And there was another study by Malas who looked at the composite outcomes of venous alone in excess of 8,000 patients. And the overall venous thromboembolism rate was 21%, DVT 20%, pulmonary embolism 13%, but the acute thromboembolism in the arterial system was only 2%. But these results were higher in the intensive therapeutic unit environment as we expected, as you will see in this slide. But the unfortunate thing is that in this meta-analysis and reviews, there were high heterogeneity in the studies related to bias, the population type, the settings, and the prevalence of venous and arterial thromboembolism in this population. So this is not reliable. So let's look at individually about microthrombosis. Microthrombosis has been discussed previously. It's a widespread thrombotic process of microthrombosis has not been observed. There is only one report that was seen in 3 patients where skin biopsies were done, and they showed some few thrombi in the skin. But apart from that, microthrombosis has not been reported widely. As regard to the incidence of thrombosis in the community, this is again is not seen as it is seen as frequently as it is in the ITU environment. Patients, as we said, that the difference between non-ITU patient and ITU patient is this: most of the thrombotic events are seen patients who are recovering from severe infection in the ITU environment. And another thing which was also concluded from this study, from this observation, that most patients who are suffering from severe infection, they should be protected with extended thromoprophylaxis, as there is a risk which is transmitted to the community. So therefore, the risk at discharge in these patients who have already suffered from ATVT or PE in the hospital, in the ITU setting, does exist, and they do benefit from extended thromoprophylaxis. So this is just to finish my presentation. I just thought that this is a slide worth presenting. One study that was recently published from Italy suggests—
Dr. Das, kindly conclude your slides.
Yeah, this is my last slide. Either single or double antiplatelet agent does reduce the mortality from COVID-19 infection. As you will see, this is with single antiplatelet, and this is with double antiplatelets. So there is some evidence to suggest that antiplatelet might help in reducing the thrombotic burden in this patient. So the key points in this study was that the severity of the COVID-19 infection is related to the cytokine storm, hypoxic insult, and activation of thrombosis. Patients with serious COVID-19 infections are mostly seen in the intensive care units settings. Assessment of sublingual microcirculatory changes enables monitoring response to predict prognosis. There is evidence to suggest that there is an increased incidence of venous thromboembolism, but not so with arterial thromboembolism. And most of these patients are seen in the intensive care units. Thank you.
Thank you, Dr. Das. That was really wonderful. So